All righty. Let me share my screen. What are you guys able to see right now? My desktop or the PowerPoint?
The PowerPoint.
Oh, okay, good. It didn't, on my side, it didn't look like that. Let me move this over here. Okay, can you still see the PowerPoint? Is it full screen?
You know that Viagra is like a blue pill? One of the most common side effects of Viagra is that your vision starts to see blue. That's so cool.
Kayla, you're unmuted.
Yeah, I muted her. I'm trying to find my stupid pointer. See it anyway. Okay, so to confirm one more time, you can see the main PowerPoint and it's full screen. You don't see like the side panel of slides.
We do see the side panel.
Okay, I had a feeling, thank you. Weird that it's doing that. We're gonna go single screen. Sorry about that, guys. All right, is it full screen now?
Yeah.
Thank you. So apparently I haven't done this in a while because I used to do this seamlessly with 2 monitors, but okay. This is the same one that you guys have had before, but I think it's been about a year since you had it and you probably have a bigger foundation to build off of. So hopefully this is just going to be a good refresher for you guys. Let me know if I'm going too fast. That's the only thing I'm concerned about is there's a lot of stuff I assume you know, but I don't want to skip anything. So if you need me to speed up or slow down, let me know. So objectives are just to understand your electrical conduction system, what all your waves represent, how we measure things, and then put that all together to figure out what your rhythms are. In your electrical conduction, your signal is going to start at your SA node. It's going to spread across your atria and go down to your AV node, passes through the bundle of His, down to left and right bundle branches, and it's going to terminate in the Purkinje fibers. In addition to that usual electrical pathway, you also have clusters of electrical cells, and they're known as ectopic foci. So hopefully you can see that over here. I'm very sad I don't have a pointer. Can you guys see my mouse?
Yeah, we can.
Okay, that helps. So the ectopic foci, the picture on the right is what represents that. So, and if you have a cluster of cells that can be excited by electrical conduction, they can cause problems, meaning they're always there, they're usually dormant. Your heart is always going to follow the fastest pacemaker. So those aren't usually regularly pacing. However, if they do speak up, that's where you could get your PACs, PJCs, or PVCs. And they can kind of trigger other weird rhythms to start. So I just want you to know that they exist, and that if they're too excited, and that can happen just with a lot of caffeine or drugs or whatever, that can get those too excited to where they're going to cause irregular beats. So SA node, AV node, bundle of His, left and right bundle branches, Purkinje fibers, and then we also know that there's ectopic foci in the walls of the myocardium. Next we have our waveforms. So hopefully this isn't too new to you guys. You have your P wave represents atrial depolarization. So does anybody know why? I think we talked about it, at least with one of the groups last week. Do we know why sometimes the EKG looks like everything's facing up and sometimes like your P waves look upside down or your QRS looks upside down? Do you guys remember why that happens?
It depends on the angle that you're looking at the heart. And then if it's going, if the lines are down, that means like the electricity is going away from the, like where it's from.
Yeah.
If it's up, it's going towards you.
Okay, perfect. Yeah. And we're going to kind of reiterate that a little bit as we go through the PowerPoints, but that is the general explanation as to why. So when we're looking at the waves, like in this example on this slide, 9 times out of 10, we're looking at lead 2. And that's just what we use a lot of the time. It makes sense. It's kind of how we're trained. And that's why it does screw us up if you guys start looking at, like, I think AVF looks upside down. So whenever I do use examples, I use that usual lead of lead 2. There's lead 2 and V2. So it's lead 2 that we are used to looking at. And that's what these drawings are representing. So atrial depolarization, another word for depolarization is contraction. And so when I have a P wave, that is representative of my atrial depolarization, meaning if I have a P wave, that's proof that my atria depolarized or contracted. So if I have multiple P waves, like an AFib, each little jagged thing that you see before you QRS, those are all P waves because you have multiple atrial depolarizations going on. The delay at the AV node, basically anytime that there's no movement of electricity in the heart, that's when it comes back down to baseline, or they call it the isoelectric line. So the delay at the AV node, if you look here, it's isoelectric, no electricity moving, goes up to my P wave, and then I have a flat section for very short period of time before it goes on to my QRS. So that's just the delay that happens when the signal passes through the AV node. After that, you have your QRS complex, which is on the leads we look at, usually upright, represents ventricular depolarization. Your other word for depolarization is contraction. And then ventricular repolarization is represented by the T wave. And then you're going to go back down to that isoelectric line because there's a pause in the electrical movement in the heart. So does anybody not understand that foundation of concepts? Okay, so depolarization is contraction, repolarization is relaxation. As long as you guys got that, because we can't go too far off if you don't understand that concept, but I think you're pretty exposed to it. This goes back to whether or not the waveforms look like they're going upright or down. So if you're looking at your heart, you got to imagine there's a patient standing behind this picture looking at you. So AVR would be towards like your patient's right shoulder. Lead 2 would be bottom left of their body. So your electrical conduction, basically your right atrium sits up here, and that's where your SA node lives. So it's going to fire, and all this electricity eventually is going to go through your atria and make its way down towards the tip of your ventricle or to your Purkinje fibers. That general flow of electricity is going towards lead 2. So that's what we always look at lead 2, because it's easy to read based on how they teach us. And all that electricity most of it is always moving towards lead 2. So that's why everything's upright. My P wave is upright. The majority of my QRS is upright, and my T wave is upright. In reverse, if you happen to look at an EKG and you choose to look at lead AVR, what do you think all those waves are going to look like?
Upside down.
Yeah, thank you. Yeah, so everything's going to look upside down if you're looking at AVR. And the whole point of this, guys, is all the stickers that we put on the patients and all the leads that we look at, it's like as if you had a patient standing there and you have someone taking pictures 360. So somebody walking around that patient taking pictures of the electrical conduction. And what happens is with those different angles, we can see different pathologies happening in the heart. So it's possible for us to completely miss a heart attack if we don't have leads in the right place. So again, anything moving towards the lead is going to be positive deflected or upward. Anything moving away is going to be downward reflected. Your paper, as a reminder, because I think we all did that quiz. I still owe you guys gifts, by the way, for my teams that won. A lot of people did miss the measurements. So you guys, you have to have this memorized in order to be able to interpret rhythms. So your paper left to right is measuring time, top to bottom is measuring voltage. We consider when we're measuring stuff, we're looking at big and little boxes. So big boxes are usually darker outlined, like you would see right over here. It's a dark outline. And then you have tiny boxes in there. So one big box, if you're measuring time left to right, is worth 0.2 seconds. Each little box within the big box is worth 0.04. And the reason we have to have at least those measurements memorized, 0.2 seconds for a big box. I say 20 because the math in my head makes sense later, and 0.04 for small boxes. So using that information, these are all the intervals that you could measure on an EKG. So they're not, there's a lot that we don't use on a day-to-day in nursing. A lot of times you just want to get enough information to establish the rhythm. And then from there, you know what interventions we should be doing. I've never needed to know what a TP interval is or how to treat it. So usually if there's really weird things that they're trying to pick apart like that, that's when it goes to cardiology anyway. So for us, we're going to need to know the PR interval. And a P wave represents how long it takes my atria to contract. And then the flat line after the P wave represents how long it takes for the signal to pass through the AV node, right? So that's going back to this slide, atrial depolarization, and then a delay at the AV node. Those two things make up your PR interval. So when we measure it, what we're measuring is how long did it take for my atria to contract and for that signal to pass through my AV node. That should usually take 0.12, so 0.12 to 0.20 seconds. So 0.12 to 0.20. If it's 0.12 to 0.20, how many small boxes would that be then?
3 to 5.
3 to 5, yeah. Thank you, Gabe. Yeah, I'll keep an eye on the chat too if you guys want to throw questions out that way or answers. So yeah, PR interval is 3 to 5 small boxes or 0.12 to 0.20. Any questions on PR interval? So this will apply later if we're getting into AV blocks. So we talk about heart blocks, and they're technically AV blocks. What happens with a lot of your heart blocks is your PR interval is going to vary or get too long or get longer and then disappear. And it's because you have a heart block is a problem at the AV node. So what's happening is your PR interval is changing because usually because this pause at the AV node is taking longer and longer for the message to get down to the ventricles. Here in green is your QRS. So that is technically it's 0.06 to 0.06 to 0.12. I've never needed to know the lower end of normal on a QRS complex. So I've always had, I had a teacher put a little like, I don't know, saying together that QRS 0.12 or less. So it kind of rhymes. It was easy to remember. And I know whenever I measure my QRS complex, it should be 0.12 or less. The official range is 0.06 to 0.12. That's letting me know how long it takes for my ventricles to fire. Because all of this should be happening in a certain amount of time so that your heart, your conduction, stays on beat. If it takes forever for my PR interval, forever for my ventricles, forever for my T wave, then that's your patient's rhythm slowing down. ST interval, I've never needed to know the interval, meaning that time, how much time that takes, but what we do pay attention to in a STEMI, which is ST elevation myocardial infarction, is that this line right here, so kind of where you'll never need to know what J is, by the way. From where my S is over to my T wave, this majority of this should be flat or on that isoelectric line. If it is raised more than one small box, which would be 0.04, if it's raised by one small box or higher, that's considered ST elevation. TP interval, you never need to know. QT, we don't talk about it a lot. We don't measure it typically in a, like in a strip. If I'm just trying to figure out what rhythm they're in, I'm not really worried about this, but does anybody know what the problem is with the QT interval? If it's too long is usually the problem. Have you noticed at all, a lot of drugs tell you to watch out for a QT syndrome or lung QT syndrome? So has anybody seen that before? No, okay. I don't think I'm good at explaining this, but long story short, the longer it gets, the higher risk they are to go into a deadly rhythm. You'll see this a lot with overdoses. There's a lot of medications, even just over-the-counter medications, that if somebody takes too much, especially if they overdose on it, it's going to create a long QT syndrome. So that's just saying that your heart's taking longer to recharge between beats. Some people are born with it, but most of the time, only time I've ever really seen it or had to watch it was with our overdoses. But the things you have to memorize for sure would be your PR interval, which is 0.12 to 0.20. Your QRS is 0.12 or less. It doesn't want to move slides. Come on. Okay. So how do we measure a PR interval? Hopefully you guys remember this from the past, that it's a lot easier to start measuring a PR interval on a dark line. It just makes your life easier. But again, it represents the time it takes for atrial depolarization to happen and for the message to move through the AV node. And again, normal is 0.12 to 0.20, which you can see here at the bottom. Measuring your QRS, this gets a little tricky until you get used to it. Excuse me. On the picture to the right, you have two QRSs. They don't look pretty, but they can look like that sometimes. And the problem is a lot of the times your patient doesn't even have a Q wave. So for my QRS on, oh, that's, sorry, I missed that over here for your PR interval. So sorry, you're going to start measuring at the beginning of the P wave. So I have my isoelectric line. And as soon as that starts to leave baseline and climb up or down, depending on what lead you're looking at, that's the beginning of my PR interval. And then it's going to stop measuring usually at the R, which is where my cursor is right now. I would stop measuring there usually because most people don't have a Q wave. So if there's a Q wave, that's where you stop your PR interval measurement. And that's also where you start your QRS measurement. If you don't have a Q wave, you're just going to go straight to the R, meaning that this doesn't, there's nothing's even here. It's just flat until you hit right there where my cursor is. So just so you guys kind of know to adjust for that. Same thing with my QRS. If I don't have a Q, you can't measure it. So you're going to start measuring at the R. So this example on the left, there is no Q wave. It just goes up and then back down. So that's all I'm going to measure. This one happens to have a very prominent Q wave and S wave. And I'm going to measure from the beginning of the Q to the end of the S. So does that make sense?
Yeah.
Hopefully. Okay. And the more, honestly, the more you practice it, the easier it'll get. And you will just, you know, ask neighbors and experienced nurses, like, you know, where would you start measuring from this one? So, okay, sorry. I have the contractor working on our house right now. So I do have all the dogs in the room in case they start to bark and go crazy. I think that's it for that. All right. The note on the bottom of the slide, if you do refer back to the slide, because I think I shared it with everybody a long time ago. I think we're at the point where almost all literature is saying the QRS interval is 0.12 or less. You might see some texts that say 0.10 because it was 0.10 for forever and at some point it changed. So for testing purposes, at least in class, I would see what Professor Amendola wants you to know. So besides our intervals that were all part of our consideration when we're measuring, figuring out a rhythm, you have to figure out whether it's regular, irregular. The way you're going to do that is you're going to see if specifically the R wave, so the point right here and the point right there, if I measure how wide open this is, and this makes it very easy to do with calipers, those are those little like pointy things that you can use. All of my R's, we say march out, they should all be equal distance apart. So I should have the exact number of boxes between every R wave. And that's what lets me know that it's regular. And my top strip represents that. The bottom strip, if you look at it, this is one strip looking at two different leads on this patient. So you notice this top one looks pretty normal. So it's probably lead 2. Bottom one is probably AVF if I had to guess. So what I'm looking for here is, again, are my R waves equal spaced? And these look okay. Actually, I don't know. Let me see. 1, 2, 3, 4, 5-ish boxes between these two big boxes. There's 1, 2, 3, 4. There's only about 4 boxes between here, 3 big boxes between here, 3, 3. This is 4. So that's how we're determining whether or not it's regular. The rate, there's several methods that you can use to figure out the rate. What's the easiest one that isn't even mentioned here?
Count the QRS complexes.
Yeah, that's the quickest way to do it. And besides that, all of our monitors tell us our heart rate, right? So most of the time you don't even have to count anything. If you need a quick rundown on, hey, it didn't give me what the rate is, I'm just going to try to figure it out real quick, then yeah, you're going to count your QRS complexes and multiply 10. Most of the time your monitor is going to give you a rate. The thing that happens though is people depend so much on the monitor that they start thinking, they're like, oh, my patient's heart rate is 210. And I've had that before. Well, what happens sometimes if my patient has, we'll say the heart rate is 200 on the monitor. If your patient has too high of a T wave, so if they have high voltage on the T wave, your monitor will count that as a beat. So if you have a patient at 100 beats per minute, but the T waves are high voltage, your monitor is going to count it as 200 beats per minute. So you always have to, again, with monitors, you have to use common sense when you're looking at them. But this is our quick way to figure out the heart rate. So here, if I have 4 QRS complexes, 4 times 10 is 40. So this is a very slow rate. These two are just an FYI. I don't think you'll ever use this, but there are other ways to manually count the heart rate. One would be to see how many big boxes are between R waves and divide that number into 300. The other more accurate way is to count the number of small boxes between 2 R waves and divide that into 1500. So the example here is if I have 5 big boxes, I divide that into 30, that gives me an approximate rate of 60. And then small boxes are your most accurate. So hypothetically, I have 21 small boxes, that always gets divided into 1500, and that gives me a rate 71. Yes, there's my pointer. Okay, that was weird. Any questions so far? All right. So I don't care how confident you guys might feel with rhythms, because some people might be like, oh, I got this. You have to make sure you hit all your steps, because if you miss one small component, that's really weird. Sorry, weird phone call. If you miss one component, it can actually change the definition of that rhythm. So for here, we're always going to look at the rate. So is it fast, slow, or normal? Regularity, is it regular, irregular? If I have 1 P wave for every 1 QRS, that's super important, because my atria should contract 1 time for every 1 time my ventricles contract. And then your PR interval is a big consideration. And you'll notice I didn't even put QRS measurement on here, because it's not that it's not important, but I'm trying to give you just if you walked on a tele floor tomorrow, you should be able to do this. And QRS complex isn't always a big factor in our determination. So here, what's my rate here? And we're going to be working on these rhythms together. So I want some feedback from you guys.
70.
Yes, 70. So 1, 2, 3, 4, 5, 6, 7 times 10 would be an approximate rate of 70. Does it look regular or irregular?
Regular.
Regular. Okay. So these, and there's some that I'm just going to have to give you the answer because we don't have like measurement tools, right? This is regular. And then is there 1 P wave for every 1 QRS?
Yes.
Okay. And I can't stress that enough. This one's super clear, but I still to this day will go P QRST, P QRST, P QRST. Because if one of them is missing a P wave, it's a total different rhythm, or it's at least there's something else you need to add to that explanation. So that is super important. So this rhythm, sorry, I gave it away. I'm sure you figured it out. This is normal sinus rhythm. Nothing's wrong with it. And the last thing we need to do is measure our PR interval. You can use any beat to measure that PR interval. Which one would be the easiest?
The first one.
Yeah, so PR interval, we measure at the beginning of the P as soon as it leaves baseline. That happens to land on a dark line. So if you can find a beat where that P wave lands on a dark line, it's gonna make your life a lot easier. My PR interval should never be more than 0.20, meaning that my PR interval should never extend past 1 box. So if that's the case, that means if I start measuring here, I started on a dark line, my PR interval should end before I hit my next dark line. So a lot of nurses will be able to just find a P that lands on a dark line, glance at it, and know it's not a problem. I may not have an exact measurement because I didn't count the little boxes, but I know it's not any kind of a heart block. So this PR interval starts here and goes to here, which is 3 small boxes. So what is that measurement?
0.12.
Perfect, 0.12. Okie dokie. So yeah, this is normal sinus rhythm with a Q or PR interval of 0.12. So this one, what's my rate here?
$130.
Perfect. 130, so I have 13 QRS complexes times 10. Is that fast, slow, or normal?
Fast.
Definitely fast. Do I have 1 P wave for every 1 QRS?
Yes.
Yeah. You'll notice as your rhythms get faster, your P and your T start to get kind of squished together. So this is an easy place to kind of lose that. But I have P QRST, P QRST, so on and so forth. So yes, there is 1 P wave for every 1 QRS. Which PR interval do you want to measure? Which one would be the easiest?
I'd say the fourth one.
Yeah, this fourth beat, again, my PR interval starts right on a dark line. Glancing at it, it doesn't go past the next dark line, so I'm already not worried about a heart block. And then if we had to actually put a number on it, it's 1, 2, 3, 4 small boxes, which is a measurement of what?
0.16.
Perfect, 0.16. So my rate's 130. I'm regular. I have 1 P wave for every 1 QRS. My PR interval is 0.16. So what rhythm is this one?
Is it sinus tachycardia?
Yep, perfect. And you might see, like in charting, I might say ST for sinus tach. This one looks a little funky. What's my rate?
50.
Yeah, 50. So I'm super slow. Am I regular or irregular?
Regular.
It's regular. Do I have 1 P wave for every 1 QRS?
Yes.
Yeah.
I do. Good. What PR interval? I think this was kind of a bad example. I think the PR interval is technically a little too long. PR interval on this one, there's not one that lands on a dark line, so you can pick whatever. This one happens, let me see. I don't know, maybe start with this one. This would be 1, 2, 3, 4-ish, maybe 5 small boxes. It's kind of hard because of the shape of it. So I'd say 0.16 to 0.20 if I had to guess on the PR interval. So it's the only thing that's wrong with this rhythm.
Slow.
Yeah, it's just slow. So what do we call that?
Sinus Brady.
Perfect. And then that'll be abbreviated as SB. This is the one I feel like we don't see it as often. Most people are pretty unfamiliar with it. I do have a rate of 50, and I want you guys to ignore that in this case. So we'll say the rate is 60. I don't want you to get hung up on the bradycardia part. We'll say it's 60 is my rate. Is it regular or irregular?
Irregular.
Definitely irregular. Do I have 1 P wave for every 1 QRS?
Yes.
I do. And then which PR interval would you like to measure?
The third one?
Yeah, I'd probably pick that one too. And then that lands probably right at, it starts here and it's going to stop right about there. So this is probably exactly one big box wide. So what's the measurement on that?
0.20.
Perfect, 0.20. So we're going to say it's a normal rate. It's a regular. There's 1 P wave for every 1 QRS, and my PR interval is normal. So does anybody know this rhythm? It starts with sinus, if that helps.
Sinus arrhythmia?
Yes, good job. Very, very rarely does anybody get that. And it's because we don't talk about it a lot. This tends to be kind of a normal variation in people to where they're otherwise healthy. It's just irregular. I think anytime I've really seen this has been in like younger adults who happen to have it. So that's sinus arrhythmia, sorry. Does anybody want to skip all the steps and just tell me what this rhythm is?
AFib.
Yay. Yeah. So AFib's really hopefully obvious now that you guys have been you know, seeing it for a little while, you should still go through your steps just to make sure, but this is one of those ones over time, it's just going to click the second you see it. So this is 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So my rate is 100. I don't have 1 P wave for every 1 QRS. So technically each little waveform represents atrial contraction. Instead of 1 P wave with 1 atrial contraction, the problem with fibrillation is that you have your atria are quivering. They have all these multiple little contractions. So you can't measure the PR interval on these, just so you guys know, it's just unobtainable. So my rate's 100, it's irregular. I don't have 1 P wave for every 1 QRS, and I can't measure my PR interval. So this is AFib. Just as a reminder, your normal conduction through the heart is SA node to the AV node, left and right, you know, your usual one. The one on the picture on the right kind of shows you, like, it's a visual representation of, I have things firing off at all points in my myocardium, in my atria. So they're just freaking out. And if you look on the picture on the left, you have, you know, infrequent signals heading down to my ventricles to tell them what to do. The only reason my ventricles ever contract is because my signal from my atria, ideally my SA node fired, and that signal eventually got to the ventricles and told them what to do. What happens in AFib is you have a ton of signals coming down to the ventricles, and there's a point, like in a refractory period, that they can't fire. So it might send down 10 signals, and the ventricles can only respond to 4 of them. Does that make sense? They're getting more signals than they can handle?
Yeah.
Okay. So because of that, that's why it's irregular. I'm having all these like random P wave signals coming down, and every so often your ventricles are able to reply to one of those. So with that, what you're definitely going to hear in ICU is AFib RVR. It stands for, obviously, atrial fibrillation. The RVR stands for rapid ventricular response. All that means is that my patient's in AFib and their rate is over 100. So that's your cutoff. So if I could have AFib RVR at 105, at 120, at 130, but anytime it's over 100, it's considered AFib RVR. Because my ventricles, they're getting all these signals, and they are now responding more rapidly to all those signals getting sent their way. Any questions on that concept?
Is AFib RVR the same as AFib uncontrolled?
That's a good question.
I just know that we learned if it was like over 100 beats per minute, then it's uncontrolled.
Okay, yeah. Because I'm thinking, like, to me, controlling AFib is being on an antidysrhythmic at home that kind of convert you out of that. That's what I was kind of thinking with that. But yeah, that makes sense too. So uncontrolled AFib or AFib RVR.
Okay, thank you.
Yeah. And so physiologically, what's the problem here? Like, what kind of symptoms is this patient going to have if they're in AFib RVR at 140 beats per minute?
Short of breath, fatigued.
Yeah. So I have atria that are quivering. They're not kicking a good volume of blood down to my ventricles to begin with. Now I have ventricles contracting so frequently, they don't have time to fill. So it's going to reduce your overall cardiac output. And that's never good. There's no filling time. So my cardiac output sucks. So your patient's going to be tired, short of breath, fatigued. They usually come in relatively symptomatic. So do you know what medication we give for this?
Amiodarone.
Yeah, good. Get real comfortable with amiodarone, okay? Your patients can get it prescribed at home and take it. If they come in symptomatic with AFib RVR, we will usually, it can change per hospital policy, but we usually give them a big bolus IV of 150 milligrams. And then they're going to stay on amiodarone drip for 24 hours. So the first 16 hours is at 1 milligram an hour. And then the subsequent 8 hours is at 0.5 milligram an hour. And usually, even though you're not really titrating this one, there's still going to be ICU status. So if you walk into a room and your patient's on amio, I can guarantee you they were in AFib at one point, or they have a history of AFib. So those are those little cues you're pulling from your room when you walk in. Any other questions on this one? Yeah. All right. That one you're going to see a lot. Atrial flutter, short version is basically the same pathology. My atria are firing more frequently than they're supposed to, but instead of being this chaotic, it's a little bit more organized. So I'm still going to have multiple P waves to one QRS. I'm still going to have, risk of clot because blood is stagnant in my atria for, staying still longer than it should. But the only difference between AFib and a flutter is that flutter is just more organized, which if I had to pick with my patient being one over the other, I'd rather them be in a flutter because this is a little bit better than this, right? You will have patients that are able to go into a flutter. They'll be AFib, A flutter, and they'll bounce back and forth, or sometimes they'll be AFib, sinus rhythm, A flutter, sinus rhythm, AFib. So just know that it kind of just depends on what their heart's doing at the time. Any questions on the flutter? And then it's also called sawtooth. There's a handful of flutter rhythms that really do look like the edge of this saw. All right, what's my rate here?
$180 if I counted right.
Yeah, you're right. It's 180, super fast. Is it regular or irregular?
Regular.
Yeah, it's regular. And then is there one P wave for every one QRS?
Kind of.
Kind of. Okay, that's a good answer, actually. If you have, you have your P wave, QRS, T, there's usually a flat line, and then your next beat comes. As your beat gets faster, all that crap gets shoved together. So what you're seeing here, it could be a P wave, it could be a T wave. It's probably both sitting on top of each other, okay? Any guess as to what this rhythm is?
SVT.
SVT, yeah. So it's supraventricular tachycardia. And that's usually if your patient's in a heart rate over 150. Your patient can technically be tachycardic over 150 without it being, like when you guys exercise, if you're running on the treadmill, it's over 150, you're not in SVT. But a lot of the times if they're coming in symptomatic, this is what it is. So what do we give for this? What can we do?
Adenosine.
Yay, adenosine. So it's the whole, did you turn it off and back on again? You're gonna stop the heart for a second and then hopefully it restarts in regular rhythm. What's the first thing that we try to get people out of SVT without getting too invasive?
Bearing down.
Yep, they're gonna bear down like they have to poop or push out a baby, something like that. They're gonna bear down. So a lot of times that stimulates the vagus nerve, converts them out of this, and they're fine. You will find that your patients who have a history of SVT, they know this, they can feel it. They'll start to feel palpitations or have some kind of symptoms that they identify. They'll check their pulse and they'll go, oh man, this thing's through the roof. Okay. And then they'll bear down and sometimes they'll just convert themselves out of it. I've had plenty of circumstances where that's been the case and the patient kept going into SVT, coming right back out when they bared down. And then they're like, yeah, it's been going back and forth for a couple of days, but I think I'm just stuck in it now. And then they'll come to ER. So it's just kind of weird because some people can live with this and bear down at home and be fine, but it is still an emergency. They are high risk for things to happen. So we always want to treat this if we can. So first thing you're gonna do is have them bear down. If that doesn't work, the second thing is to give adenosine. I keep saying I'm gonna look this up. I gotta write it down. So adenosine, we've always been able to give 6 milligrams, a second dose of 6 milligrams, and then the third dose is 12 milligrams. It's possible it got cut down to 1 6 milligram, 1 12 milligram. And every time I give this lecture, I was like, I need to look it up because I thought I heard it change. That chemically stops the heart for a second. Very, very brief. Your patient feels super weird when it happens. I've heard them say they get a sense of impending doom. They have chest pain. They can't breathe. Feels like their chest is caving in. Bunch of weird sensations. We're not going to tell them like, hey, this is going to stop your heart for a second, but you'll be fine. We're just going to take precautions. So ideally have the crash cart in the room, pads on them. I think I told one of the groups I had this happen one time. We'd always put the pads there just in case. And the doctor literally would not let me put the pads on the patient. He's like, no, just give it to him. He wouldn't let us bring the crash cart in. And the patient went into VFib after we gave this. Like he started to lose consciousness and went pale. Luckily he came out of it before he actually coded, but that's why we keep the pads on the patient just in case. So bear down, adenosine, 2 to 3 rounds of adenosine. And then if that doesn't work, what can we do? Any guesses? I know somebody's got to know this.
Would it be to shock?
Yes, you're going to shock them. So when we shock them, are we defibrillating or cardioverting?
Cardioverting?
Perfect, cardioversion. So this is a quick representation on SVT. A lot of times they'll call it re-entry tachycardia because my signal goes down where it's supposed to, and your signal should die off in the Purkinje fibers. But people who have SVT, they will have this extra pathway that allows that signal to go back up into the atria instead of die off in the ventricles. And the heart basically gets stuck on a loop. So that's what's happening with this. And by either shocking it or giving medication or having them bear down, we're hoping to kind of stop that loop to where that signal can die off in the ventricles, and then we can restart a normal cardiac cycle. So cardioversion versus defibrillation. I don't know. Yeah, I get into that next. Okay. So cardioversion, I'm fairly certain, I don't know if we have this function on our monitor. I'm going to have to check, but when you have an alive patient with a pulse that is in a rhythm you don't want them in, we can shock them, or the proper term is cardiovert, meaning that we're trying to convert the rhythm using electricity. Your patient is usually awake for this. We'll give them like pain medication or Versed or something like to calm them down because it hurts. We're literally shocking them. So if your patient's, alive with a somewhat organized rhythm, SVT isn't ideal, but it's still organized. I still have a PQRST going on. We're going to cardiovert. Cardiovert is actually, synchronized cardioversion means that you're shocking at a very specific point in the cardiac cycle so that you don't cause cardiac arrest. All right. So what we do here is we'll put them on the pads, hopefully give them some kind of pain or sedative just to make them a little loopy for this. And then do you guys see the white circle here? These white dots above those beats let me know that the monitor has now synced up with my patient. So you start from scratch. I'm going to put pads on my patient. I'm going to turn this dial from off over to defibrillate. So that kind of puts it in the mode that it can shock. And then down here where it says sync on/off, I'm going to hit on. And when I hit on, I'm going to start getting these white marks. And that lets me know, like I said, that my monitor has synced up with my patient's cardiac rhythm. Do you guys remember, because I think we talked about this in at least one group, what happens if I try to sync up, like I try to read the patient's rhythm and try to shock at the right time? Do you know what can happen?
If you shock during, I think the T wave, don't they flatline?
Yeah, so if I shock and I end up, that shock puts an R that lands right on top of my patient's T wave in their cardiac cycle, it can throw them into cardiac arrest. So at some point they figured this out and we stopped trying to time it. Because if I have a heart rate of 180, I don't want to try to time that shock at all. So that's why these machines are made like that. Put them on the pads, put it on defibrillate. You have to hit sync because that's how the monitor knows when to shock. And then I'm still going to charge. And when this lights up, I'm still going to shock. So it's going to be all kind of the same process. Everybody clear of the patient. Patient's not going to like it. But the idea is that when I throw that, that shock in there, it's going to reset. So that's what this picture is down here. You have a patient, you can cardiovert AFib. I have never seen it. We usually control that with medication, but down here I do have, looks like AFib RVR. You can see that there's a big discharge, like high voltage from us shocking the patient, and they actually convert it into a normal rhythm down here. So that's all cardioversion. You can cardiovert different rhythms. More often than not, it's going to be SVT if you're cardioverting. So any questions on that? And you might see on the slides here, you can shock them more than once. So we might, we'd rather be conservative with the voltage because it's going to hurt. So if we can start at 50, awesome. And if 50 works, awesome. If it doesn't, we might crank it to 100 and see if that works. So they might get shocked a couple times, unfortunately. All right, what's this rhythm?
VTAC.
Yes, VTAC. So looks like tombstones. People say tombstones. What's the difference between VTAC and torsades?
Torsades has like the V fib rhythm kind of blended in there.
Yeah, so this VTAC is kind of a high voltage. And then if you go over to V fib, there you go. This is V fib. This is lower voltage, right? With torsades, it's torsades de pointe it's like French for twisting of the points. And so what it looks like is twisted. I don't think I have that on here. I need to add that in here. Oh, here. This is kind of looks like torsades. My voltage is higher, gets a little bit smaller, gets a little bit higher. And it kind of looks like if you were to take streamers and twist a streamer, and it kind of goes wide and then skinny at the point that it twists. That's why they call torsades that. All right. But yeah, so VTAC, I held so many labs. I don't know who I talked to about what. I'm assuming it was your cohort, but so VTAC, it has to be pulseless VTAC, meaning that my patient's unconscious, they're in cardiac arrest, and this VTAC, I can defibrillate, I can shock at any point. We did talk about it is possible for your patient to be in sustained VTAC, meaning that they are awake with a pulse, but they're just in VTAC, and that just gets controlled by medication, unfortunately. I've seen it happen once, freaked me out. That guy was in VTAC for hours. And I think it was partially a pacemaker issue, and they had to call the pacemaker company out, and it was weird. So as far as defibrillating this, it has to be pulseless VTAC, or it'll be a PVT. Any questions on VTAC?
Can you give amiodarone for VTAC?
Yes. We can do 1 round, I think, per ACLS, because I think it goes like 2. I think you do 2 rounds of epi, and on the 3rd round we can give amio. I'm like 90% sure on that. Okay. We don't tend to give a lot, but it's like it seems. I mean, it's a good medication. We've probably used more of it, but let's see how it is. Let me see if I can find it really quick. So we just epi it up the whole time.
I think it was on my medication card. And
yeah, we give 2 doses.
Oh, okay.
So, because the first dose, and it'll be in the crash cart, your first dose is always 300, and the second one is 150. But I feel like I don't see it here, and I don't know if this is the most up-to-date one, but it was, let me see. Please talk. On your 3rd round, I think is when it's okay to give amio. And I don't know why. This is like American Heart Association studies all this stuff, and they just send out their recommendations. Any other questions? All righty. So here I have actually what looks like torsades, huge discharge from my defibrillation, and then your heart starts to go into a normal rhythm here. What's this one?
V-fib.
Yeah. So if you, can you shock this one?
Yes.
Yes. So there's your 2 shockable rhythms. Which one's worse if you had to pick, V-fib or VTAC?
V-fib.
V-fib, anything getting closer to a flat line is bad. Okay. So again, we're still going to continue CPR, both rhythms. We can keep giving epi, we can give, keep doing CPR for both. And these are the 2 that we can shock. What if I have what kind of looks like normal sinus rhythm, but there's no pulse with it?
PEA.
Yes, thank you. PEA. So it's pulseless electrical activity. What in that case, basically the electricity is moving through like it should, but it's not, your myocardium, your muscle is not responding to what the electricity is telling it to do. So even though on the EKG it looks normal, and let me go back. It'll look pretty friggin' normal sometimes, like something like this, something like that, something like that. When you have PEA, it's the electricity is moving to where my waveforms look correct, but if it's not generating a pulse, that means my myocardium is not listening to those signals. So I don't have a pulse, so my patient's still coding. So we cannot shock PEA. We're just gonna basically pause, check the rhythm, check for a pulse. There's no pulse. That is not a shockable rhythm. We're going to jump right back into our CPR. Any questions on that one? And our last two rhythm is agonal and asystole. So if you have seen someone die or dying to where we're not actively resuscitating, you'll notice you don't flatline right away. You'll have these, what we call agonal beats, that just wide complex QRSs. And it's kind of the last of the electricity moving through the heart while they're passing. And then asystole is not usually a dead straight line, like on Grey's Anatomy. We never shock asystole, by the way. Asystole is your actual flat line. So it actually might take a while for your patient to hit asystole. If you've called time of death, they might still have something going on up here. Any questions so far? All right. This one, you're just gonna have to practice strips and kind of get used to it. My first one we're gonna address, they're premature complexes, meaning it's a beat that showed up early and it came from something other than the SA node. All right. So this top rhythm, if I were to just interpret it like we usually do, this is 1, 2, 3, 4, 5, 6, 7, 8. I have a rate of approximately 80. It doesn't look regular. Do I have one P wave for every QRS?
Yes.
I do. And then if I measure my PR interval, that's the only thing, is that the PR interval varies a little bit on your extra beats. But which out of this top one, which beats do you think showed up early?
The second.
Yeah,
and
number 2 and 7. Right? These can get a little tricky, guys. So if you think your patient is having PACs, you might sit there and watch the rhythm for a minute, like as it's moving, and you'll see it, because when they have premature beats, usually the underlying rhythm is pretty regular. So if I just cut out this section of, these 4 beats out of my QRS, or out of my rhythm, if I just cut out this section, this looks like a normal rhythm. And if I space these out, they're all evenly spaced. And then my next beat should have showed up here. So that's what you're trying to look for if you're trying to figure out what this rhythm is and see if they're just PACs or PJCs, is you're trying to look to see, hey, is the majority of my rhythm relatively normal and regular? And is it just these handful of beats that are showing up that's throwing it off? So this one is early, that one's early. The reason I'm calling it a PAC, meaning premature atrial contraction, is because when I look at my P wave, it's upright. So something generated from my atria, when looking at lead 2, I should have an upright P wave. Another tip that might help is the morphology or shape of your P wave is usually different on your premature beats. So if you look at these P waves, not part of my premature beat, they're shaped relatively the same. If you look at the P wave on my premature beats, these P waves are like kind of taller and skinnier. So the morphology or shape of the P wave looks different on my premature beats. So what I would call this would actually be normal sinus rhythm at 80 with premature atrial contractions, or PACs. Questions on that concept? Alrighty. PJCs can show up 2 different ways. Same thing, your underlying rhythm is probably like regular, your R to R is spaced out evenly, but I have a couple of early beats. So if I'm looking at this one, this guy's early. And that's actually the only one. You'll notice that it's going to basically go back into a normal rhythm over here. PJCs is the reason I know where this came from and that it's not the atria, is that my P wave is upside down. The other way a PJC would show up is there's no P wave. So if you look at the strip down here, I'm good. This dude showed up early. It's totally flat. So no P wave, it goes into my QRS. Starts again, and then this guy's early, totally flat, no QRS. So the reason this is, if your SA node fires and your atria contract, you're going to have an upright P wave. That's what the upright P wave represents, is atrial contraction. a PJC, junctional contraction, you got to think of junction and AV, like the AV node, as kind of the same thing. They're coming from the same area. So if I have a PJC, it's a premature beat that didn't happen or exist in my atria at all. It's starting at my AV junction or at my AV node and going down from there. Does that make sense?
Yeah.
Okay. With the PJC, since they start at the AV node and go down, you could have some backflow of signal, which is why my P wave is upside down. Or it can be flat, meaning nothing went backwards, it all went forward, and we just started at the AV node. So I'm going to ask one more time. Any questions on these? I know they're a little funky. All right. PVCs are really hard to miss. Okay. Again, you're going to have a relatively normal rhythm under it. So if I spaced all these out, these are happy, right? But then I got my next beat should have showed up here, and instead it showed up here. So this beat is early. And really, guys, with PVCs, because it's generated from the ventricles, they are very, very wide, complex beats. So the beat showed up early and it's super wide, complex. That's how you identify that as a PVC as opposed to PAC, PJC. So PAC, it's early, P wave is upright. PJC, it is early and either inverted P wave or no P wave because it starts at my AV node. And then a PVC, it's early and it's, they're big, fat, and ugly. They're really wide, complex beats that showed up early. I feel like we see these more often, but honestly, it's probably because these are easy. I can walk by a room and pick out a PVC. It's a little bit harder to do with these ones. So, any questions on the premature beats? Okie dokie, you guys are doing good. Heart blocks. So I swear by the heart block poems, guys. You could Google this heart block poems, or it's on Pinterest or whatever. I'm sure Insta's got it too. These poems really do help. And because heart blocks can be easy to misinterpret sometimes, I will still say these poems in my head. And as I'm saying, I'm like, okay, I think this is a secondary type 2, but I'm going to say the poem and make sure the poem makes sense for this rhythm. So, these are your heart blocks. I'm sure you've heard them before. For a first degree heart block. So this is very early in this pathology that's developing, and there's just a delay. Again, I have my P wave, which is atrial contraction. And for that signal to pass through my AV node to get to my ventricles to tell it what to do, that's taking too long. And that's why they call it heart block, because it's a block between my atria and my ventricles. So for my first degree heart block, if the R is far from P, then you have a first degree. That's your poem. If I look at, I'm going to measure this P wave, it starts on this dark line. And where should it not go past?
Point to the next dark line.
The next dark line. And this is exactly why we try to measure one that stands on a dark line. I can look at this, see it goes past my next dark line, and I'm already like, ah, crap, we got something going on. What you do need to check with these, so we'll look at our rate, 1, 2, 3, 4, 5, 6, 7. My rate is 70. It looks regular. I do have 1 P wave for every 1 QRS. And the one thing you have to watch if you're suspecting a heart block is you need to kind of check all of your PR intervals to make sure they're the same. In a first degree heart block, they are all equally too long. So this one is 1 big box plus another, we'll call it 6 small boxes. 6 times 4 is 24. So normal PR interval is 0.12 to 0.20. This one's rating at 0.24. You could argue a little bit longer if you wanted to. But this one, all of these are equal distance. So they're all too long. So that's a first degree block. If the R is far from P, then you have a first degree. My signal's getting held up in my AV node too long. There are 2 types of second degree rhythms. There's a second degree type 1. The other name for that is a Movitz 1. The other name for that is a Winky Bach. The only thing that sucks about this poem is you have to remember what a Winky Bach is. The poem here is longer, longer, longer drop than you have a Winky Bach. So what you'll notice on this is my rate is 1, 2, 3, 4, 5. So this happens to be bradycardic, which is fine. I have one P wave for every one QRS. Let me know if you see that.
No.
This is why we check that. So P QRST, P QRST, P QRST, P, nothing. I have a dropped QRS, and then it starts over P QRST, P QRST. So what you're going to notice in this rhythm is you're going to have P waves that don't have a QRS associated with them because that whole beat got dropped. What's happening here is on this beat right here, my PR interval looks just about normal. So my atria fired, signal got to my ventricles, and we're happy. The next one, my atria fired, and it took longer for the signal to get there, but it got there. My ventricles fired. My next one, it took even longer to get to my ventricles, and it fired. And then this one, I have my atria fired, SA node fired, atria contracted. Nothing got to my ventricles, so I don't have a QRS complex. Go ahead.
Winky Bach. Sorry, I'm just confused with like the alternate names. So second degree type 1 is the same as Winky Box?
Yeah, so they have, and I think it comes from like whoever discovered it or whatever. Yeah, there's second degree type 1, second degree type 2. Second degree type 1 is also called a Mobitz 1, and it's also called a Winky Bach. That's the part that's not helpful because you're like, I have to know all of this. The one thing I want you to take away also is the poem is longer drop. And here we see a longer QRS or longer PR, longer and a dropped beat. It's not always 4, okay? It could get longer and dropped on the 3rd beat, on the 7th beat. I do want you guys to know that it can vary. So if the R is far from P, then you have a first degree. First degree heart block, all my PR intervals are the same, but they are all too long. Second degree type 1 or Mobitz 1 or a Winky Bach is the longer drop, then you have a Winky Bach. My PR interval is getting longer and longer until I have a P wave with no QRS attached. Any questions on those? All righty. This is a Mobitz, so second degree type 2. Other name is Mobitz 2. It does not have a 3rd name, thank God. This poem is, if some P's don't get through, then you have a Mobitz 2. The idea here is that I have random P waves with no QRS because on this one, for example, SA node fired, atria contracted, and that just flat out didn't get to my ventricles. So I lost my QRS. What you'll notice on this one is your PR interval is normal and it's the same on any one that you can measure. So if I look at this beat, this is a short, what looks like a normal QRS. This one's missing one. This one's normal QRS, or sorry, PR interval. Normal PR interval. I have a P with no QRS. Normal PR interval, missed by QRS. So hopefully you'll notice it looks irregular for sure because you're missing these QRS complexes when they should be there. My PR interval, there's not like a growing delay at my AV node. Sometimes it either gets there or it doesn't. Any questions on this one? Go ahead.
So pretty much the only difference between type 1 and type 2 is that type 2's PR intervals are all the same, but type 1 is like they can be different.
Yep.
Length.
If you have that's kind of a key too. If you have changing PR intervals, it automatically makes it a second degree type 1 because your PR intervals aren't changing. Sorry, second degree type 1, yeah. Because on my first degree block, my PR intervals don't change. On my second degree type 2, my PR intervals don't change, the ones that I can measure. Only the second degree type 1 is when you have that change where it gets progressive and drops, progressive and drops.
Thank you.
You're welcome. And honestly, guys, sometimes you're looking at it and you're like, is that a PAC or am I like, sometimes it's just, these are weird. You don't see them very often. And I'll just say in my head, like, okay, if the R is far from P, well, no, because this PR interval is fine. Longer drop. Oh yeah, okay, this thing keeps getting longer and then I have a dropped beat. That's it. Like I still rely on these poems. Not as much, but it'll get better. We're good on our type 1. sorry, first degree block, second degree type 1, second degree type 2. Okay, third degree heart block is also called a complete heart block. So what do you think is happening at the AV node? Any guesses?
Blood is not leaving the ventricles?
No. So good guess. I appreciate you jumping in. All of your heart blocks is there is more and more delay or interruption from the signal getting from atria to ventricle. So at that AV block, that's why they call them AV blocks, at that atrial ventricular junction between the two, or top or bottom of the heart, that signal from the atria getting down to the ventricles is getting more and more disrupted. So my first degree block, it's just taking longer. My second degree block, it takes longer until I lose a complex. Now I'm just losing random complexes. And then a third degree heart block is also considered a complete heart block, meaning that my atria and ventricles are not talking at all. So this one is always bradycardic. I don't think we covered it. So how fast does your SA node usually fire?
60 to 100.
60 to 100. What about your AV node?
40 to 60.
40 to 60. Okay. And then your Purkinje fibers?
15 to 40.
Okay. 15 to 40, which it's usually 20 to 40, but I believe somebody pointed out that your textbook is saying 15 to 40 now. So maybe that changed. But the deal here is that my P wave represents that my atria are firing. So if you look at this rhythm, if I go and look at all my P waves, I have a P wave here, there should be one here, and there's kind of a weird bump. So maybe that's it. P wave, all my P waves march out. Okay. And if you look at their rate, this is 1, 2, 3, 4, 5, 6, 7, 8, 9. My atria or my SA node is firing at 90 beats a minute. And as it fires, nothing's getting to my ventricles. So if your ventricles are not being told what to do, they will fire on their own, which is your Purkinje fibers. And that's why we have to know that the Purkinje fiber rate is 15 to 40, because if they're not being told what to do, they're eventually going to kick in. So what's your ventricular rate here?
30.
30, yeah. So when you have a complete heart block, we usually, when you got to think about it, whenever we check a rate on a rhythm, we always go by QRS complexes, right? So if I said, hey, what's this one? 1, 2, 3, 4, 5, 6, 7. 7 times 10 is 70. Have you guys realized that you can actually figure out the atrial rate versus the ventricular rate?
Would the atrial rate just be counting P wave?
Yeah, that's it. So especially if the patient gets sick and you get more heavily into cardiology, whenever we look at a rhythm, I'm like, oh, what's the rate? We're technically always going by the ventricular rate, but you can count them out individually. So this, for example, let's say count P waves. This is 1, 2, 3, 4, 5, 6-ish, 7, 8, 9, 10, 11, 12, 13, 14. So I have an atrial rate of 140. I have a ventricular rate by counting my QRSs of 70. So what happens in your third degree, is your atria still doing its job? It's still firing at, I think, 70 or 90. Your atria is still doing its job. And again, whenever your ventricles aren't being told what to do, they're not getting any signals. They're like, okay, I guess we'll do our job. They'll kick in at 15 to 40 beats a minute. So these patients will always come in at what we consider our usual, our rate, because we look at the ventricles, they'll come in at like 35 beats a minute and they don't look good. Okay. Because there's been a total block between my atria and my ventricles. So there's only one way to fix this. Do you guys know what that is?
Get like a pacemaker.
Yeah, you actually have to have a pacemaker. 1, 2, usually a ventricular pacemaker, because your atria clearly are firing fine. They're firing at 90 an hour or 90 a minute. So you need something to regulate your ventricles, because your ventricles have lost all signal. So any questions on the heart blocks? Okay, we're just going to kind of loosely cover STEMIs. So it stands for ST elevation myocardial infarction. Looking back at, let me see. That's funny. Okay, we'll start with the EKG, I guess. So not every hospital is a STEMI center. I'll start with that. To be a STEMI center, you actually have to go through like kind of like accreditation process. You have to do an ungodly amount of paperwork, submit it with the state, all kinds of crazy stuff. So just so you know, not every hospital can actually handle a STEMI. The paramedics know that. So if they're picking up a symptomatic patient that's having a heart attack, or they're suspecting having a STEMI, they'll go to the nearest STEMI center if they can. To be a STEMI center, you have to have all of these things in place to handle a STEMI. So one is eventually all of your staff has to be trained on how to manage a STEMI. They have to get to cath lab. So a STEMI center, they have to have an average time of 90 minutes from door to balloon. Have you guys ever heard that before?
Yeah.
Okay. So door to balloon means the second they walked foot in our hospital to the time that they're in cath lab getting an angiogram and there's a balloon opening up the blockage causing the heart attack, we have 90 minutes to get that done. So for example, working in ER, we were trained that, hey, like everybody jumps in on a STEMI, we're time stamping everything. And they're usually out of ER within 30 minutes. So that's why we so quickly do EKGs on everybody in ER. If you come in with, there's like a laundry list of symptoms. If any of these symptoms fit, we're going to do an EKG just in case, because this could be symptoms of a heart attack. So we have to do an EKG. If somebody meets any of those symptoms, we have to do an EKG within 10 minutes of arrival. If we do the EKG and we see ST elevation, we're going to let the doctor know, and we're going to send an image over to the cardiologist. And between the two of them, they're going to decide whether or not to call a code STEMI. If they call a code STEMI, that's when we hit high gear. We have to, usually do 2 large bore IVs. We get blood, we type and screen, we gather their belongings, we give blood, anesthesia, and procedural consent. Like everything goes super quick. They're on the pads. They're shaved in the groin where they usually access for cath lab, and they are out the door of ER in 30 minutes. That gives cath lab an hour to get that blockage opened. So for a STEMI center, I don't care if it's 2 a.m. on Easter or New Year's or whatever, we have to have a team that can respond within 15 minutes of us calling a code STEMI. So just so you know, these hospitals that are STEMI or stroke centers, there's this whole thing that has to get put in place. And then also they track us. So if we're consistently falling out of that 90-minute window, they will take our accreditation away. Most of the time with these patients, we will just give them meds. We're going to do all that stuff, give them some heparin. A lot of times paramedics have already given them aspirin, throw them on some oxygen, and kind of be on our way. The reason we do a 12 lead is because it gives you 12 pictures of the heart. You have 10 stickers on your patient, and you got to think of every sticker or lead as a different image of the heart. So just like we talked about before, that, if you look at different angles, you're going to see different stuff. So if I'm staring straight at you, I can't tell you what your head looks like. So I would need somebody behind you to tell me what it looks like. That's the importance of doing the 12 lead. Also important is making sure you have correct lead placement, because we actually it was a big thing at our hospital. We weren't putting V6 sticker far enough back to actually hit the mid-axillary line. And we can miss STEMIs that way. There could be people that are actually having a heart attack and we missed it because we didn't put the sticker in the right place. If you look at this paper, sometimes it's a little confusing when you look at it. I want you to notice right here, it says in Roman numerals, it says 2. This says 3. This says 4. No, 1, 2, sorry. 1, 2, and 3. There's a dash right next to it. This little section right here is V1. Or lead 1. This is lead 2. This is lead 3. We have AVR, AVL, and AVF. So this little section is AVR, AVL, AVF. Then you have V1, V2, V3. So when you look at the EKG paper, when I was new, I remember saying, like, look, I'd look at the whole line like we usually do. So this is all upward deflected, and all of a sudden now everything's upside down. And then this kind of goes back. And I'm like, what the heck is going on this line? So I do want you to know, when you're looking at a 12 lead printout like this, they're small sections of each area. And most of the time now they do have one long line at the bottom that is lead 2, because that's what we look at the most. When looking at this paper, you don't have to know this as a nurse. If you learn it, great. Paramedics are pretty good at this, and physicians as well. Depending on what leads have ST elevation, we can figure out where the heart attack's coming from. So a heart attack or an MI is just a blockage in the coronary artery. But to kind of save time and treat it faster, it'd be really helpful to know which coronary artery they need to try to get into, right? So if I have ST elevation, and if you see where all these blue boxes are, so this right here, if I have elevation in those, then that's going to let me know that it's in that diagonal coronary artery. If it's this red box right here, so if 2, 3 AVF, then I know it's in my right coronary artery. If it's in this section with V1 and V2, that's just a septal coronary artery. So gives the physicians an idea of like where to even start looking when they take them to the cath lab. Is there any questions on STEMI centers, paper?
So as nurses, we're gonna have to know this, like this picture. We're gonna have to know what these things mean, or just the physicians?
No, the nice part is you don't have to know like where all the colored boxes are. If you learn it, awesome. But the colored boxes just let the physician kind of get an idea of where he needs to go, where the heart attack's occurring. As a nurse, if I see ST elevation in 2 or more leads at all, first of all, it's going to come, it says right up top, this says normal EKG unconfirmed. It's going to say acute MI. So whenever we use these monitors, one, the monitor interprets the rhythm. It's not always accurate, but you know, my patient came in, she's a 65-year-old female with epigastric pain. That meets criteria for an EKG. So I throw her on a 12 lead, either you or your tech will do it. Throw her on a 12 lead, and then it's going to come across and be like acute MI. It's going to say it. The other thing with the EKGs, guys, even if it says acute MI, or if it doesn't say acute MI, it's a machine. It's not accurate all the time, right? So I actually have to have this go physically signed off by a physician within like 5 minutes of getting this EKG done. So it's kind of nice because it's not our call to make that determination. All you have to do is really just get the EKG done and hand it off to a physician to make the call. My job though is making sure that I know what type of patient a 12 lead would be appropriate for. Anybody experiencing chest pain, obviously, and I'm going to get this done. As a nurse, I've never had to interpret this. Like all my different leads, I've never had to know, oh, 2, 3 AVF means it's the right coronary artery. In your day-to-day job, you don't need to know that stuff. So, did I over answer your question? Sorry.
No, that was really helpful. Thank you.
Okay. Yeah, what you do need to know is how to manage it. Hey, we're in the STEMI center and I work in ER. I better know what to do. So they do kind of train you on it, and you just have to do it 100 times to get comfortable with it. Of remembering, okay, we got blood, we got a type-in screen, we have an ID man on him, we inventoried all his belongings, we have 2 large bore IVs, we, you know, all the consents and all the paperwork. That takes a little bit of time to learn. But if you ever have a code STEMI, let's say you've never had one before, you're brand new, it's just like any other code. 50 people are going to show up to help you.
If somebody that you're treating goes into like a STEMI, would you basically just like prep them with the large bore IVs and then prep them for transfer to a STEMI center?
Like somebody in the hospital that?
Yeah.
Like
if they were if you were like treating them for maybe a different heart thing. Does that ever happen?
Okay. So it's a good question, because when your patient's in the hospital, they're already sick. They're not above also having a heart attack in the middle of their hospital visit. That happens too. So even being on the floor in ICU, ER, tele, whatever, or sorry, ICU, med surg, or tele, if they're admitted anywhere of those places, those nurses should still know, hey, my patient started having chest pain or epigastric pain, or if they have shortness of breath over like 60 years old, there's, you know, those reasons I would do an EKG. If your patient meets any of that criteria, those nurses should at least know, hey, I need to do the 12 lead to rule this out. And then if that patient becomes a STEMI, it's still kind of the same process. They're going to, it's going to get faxed to a physician. ER is nice because the physician's right there. With like med surg tele, you might have to fax it over to a physician, but my patient had a symptom, it fit that criteria. I did my 12 lead, I handed it off to a physician. especially if I look at this thing, I don't know a whole lot, but there's ST elevation all over it and it says MI. Yeah, I might start doing that stuff ahead of time, even while that physician's still confirming. And you're still going to do the same thing. They're in the hospital, so they probably already have an IV. But yeah, let's start a second one. Let's page lab and get them over here to type and screen this patient. Charge nurse is going to show up with all the paperwork. So it's still the same process. It's a lot easier in ER because we always start from scratch. So we always have to do everything. So it gets really easy because that becomes routine. When they're in med surg, it's a little bit, or any other department, it's a little bit different because you have to catch that. You can't say, oh, they're here for respiratory. I'm sure it's nothing. You still have to know to do those EKGs and move forward that whole STEMI process. Did that clear that up at all?
Yeah.
What I couldn't tell you, honestly, because I've always worked in the STEMI center, is if it's a STEMI and we're not in a STEMI center, I'm curious if they would transfer that patient out.
Yeah, that's kind of what I was wondering. If you would like, so I have one other question that seems kind of stupid. Are all MIs STEMIs, or is the STEMI just a type?
That's a great question. No, thank you so much. There's two ways a heart attack can show up. They can walk in the door and I physically see this ST elevation on their EKG, and that's a STEMI. And those are the ones that we can do the whole process, door to balloon time, all that, right? The other way a heart attack shows up is in what lab work?
Troponin.
Your troponin. Sorry, I'm making a note. Okay. The other place it'll show up. So I might have somebody who's, they came in for chest pain, shortness of breath, the whole 9. We did a 12 lead and there's no ST elevation. That doesn't mean you're out of the water. Now we're going to make sure we get our troponin, and I'm going to be in the back of my head waiting for that thing to come back. So, okay, we drew troponin. All right, it's been, 30 minutes. Her labs are starting to come back. Let me check it again. And it might be no ST elevation, but then we have our elevated troponin. So those are what we call non-STEMIs, or an N-STEMI. Have you guys seen that before? So it's a non-STEMI, meaning there's no ST elevation, but it is still a myocardial infarction. I actually don't know why. I think because if you have a STEMI that shows up on paper, that's the one where like we kick into high gear and they rush off to cath lab. A non-STEMI, sometimes we just start them on a heparin drip and go on our way. So my assumption between that, it's just kind of weird because your STEMIs are such an emergency and your non-STEMIs like, well, we're going to trend the troponins. But those patients are still going to have a cardiology consult. A lot of times they're still going to go to cath lab. And in the meantime, we're going to use medical management as far as like giving heparin or something like that. Any other questions? Okay. What becomes more concerned with your non-STEMIs is if your troponin should trend up and then drop down. So if they're trending up, like my first 2 lab draws, they trend up 2 or 3, that's one thing. But if they trend up like just for days, like that's not, that patient's for sure going to go to cath lab. A lot of the times when we get them, we'll see this spike and then it comes right back down.
Okay, thank you.
You're welcome. Any questions on this stuff? Okay. I'll leave it up to you guys. Skillstat is that website that I think we used before when we did this. Let me see. So I'll leave it up to you guys if you want to practice together, or you can practice this on your own and I can kind of explain as we go. It is skillstat.com. You can go straight to ECG simulator. I'm going to play the game. And then my recommendation is I go into settings or options down here. And because when I was learning this, I didn't want to rush. I was trying to just actually work through some rhythms. I changed the game to 8 minutes. And then you have dynamic or static. So dynamic means like if you're watching a patient's rhythm on the monitor, it's constantly moving because it's constantly updating to the current rhythm. Or static is almost like printing out a strip. So if you're not confident with this, I would give yourself 8 minutes, make it static, and leave your grid on because the grid is your paper. We'll save that. All right. Let's do at least one round, and then beyond that, we'll see if anybody else wants to go. Like if you guys still want to do this. This one's nice in the sense that it gives you options to choose from. It's not nice in the sense that there are a good 10 rhythms on here that we haven't covered and you don't really need to know. So I hit play. That was loud. This is a perfect example. So this is just, this is a junctional rhythm. That is also a rhythm that exists. Junctional rhythm, where do you think that rhythm starts?
In the atrium?
No, so I would have a P wave if it started in the atria, because that means my SA node fired and my atria contracted, and I don't have a P wave on this one.
Ventricles?
Okay. How fast do your ventricles beat?
40 to 60?
Yeah.
60 to 100.
Okay. So what we're going to do, and thank you guys, I do see you on the chats participating. Okay. So my SA node up in my atria beats 60 to 100. One indication that a signal's coming from my SA node is that it's at a rate of 60 to 100. The other thing is that I should see a P wave, because that's representation of atrial contraction or atrial depolarization. My next pacemaker in my body, if my SA node isn't working or it just stopped doing its job, my backup pacemaker is my AV node. And that's the one that fires 40 to 60. And then if that gives out and stops working, your last backup is your Purkinje fibers, which is 15 to 40. All right. So based on those numbers, where do you think this rhythm's coming from now?
AV.
Yeah, it's your AV node, because SA is 60 to 100, AV node is 40 to 60. So what you should notice on this is a junctional rhythm, meaning that every beat is coming from my AV node. We have completely skipped my SA node. There is no P wave on any of these because nothing happened in my atria. And then as we know, our AV node fires 40 to 60, so it's within this range, right? These are super rare. I want to point out on the menu over here, you have a junctional rhythm, accelerated junctional, and junctional tach. So these are all the same pathology. Nothing's going on in my atria. It starts at my AV node. But this one's between 40 and 60. This one's a little faster, and this one is tachycardic.
We actually have to know this for our tests. That's all.
Oh, do you really?
Yeah.
Okay, awesome. What exactly about junctional rhythms do you need to know?
We just kind of learned that it has no P waves, or sometimes like inverted P waves. And then we learned about how junctional is like 40 to 60 and the accelerator is faster, and junctional is like over 100, I think.
Yes. Okay, awesome. This all goes back to, and I know it's super basic, it goes back to this slide here. If I have a P wave, that lets me know my atria depolarized. If I have a QRS, I know my ventricles depolarized. So if you can really remember what that means, if I don't have any P waves, that means we have completely skipped my atria. Okay. So, all righty. So this is a junctional rhythm. I actually don't know the ranges. So I think, was it Sarah, you said junctional tach is over 100, I'm assuming?
I think that's what it is, yeah.
Yeah, my assumption is 40 to 60 would be a junctional rhythm, probably 60 to 100 would be accelerated junctional, and then over 100 would be junctional tach. I'm not sure, check your textbook.
Yeah, that's right. I just checked.
Okay, cool. Thank you. I don't know. I actually don't know which one this is. It's irregular. It's slow. I have one P wave for every one QRS. I have long pauses, which is usually an exit block. I don't know. Oh, it's a sinus arrest. Okay, completely ignore that. And that's what sucks about this game. When I played it, even when I was new to all this, is there's just some rhythms you're just guessing on. But anyway, my heart rate here is 138. It looks regular. I have one P wave for every one QRS. So what rhythm is this?
Sinus tachycardia.
Yep, sinus tach. Because everything else is normal, it's just fast. She having you guys go over idioventricular rhythms or IVR?
Yeah, she is.
Wow, that's crazy. Okay. So what do you guys know about them?
Idioventricular is really slow. It's like 20 to 40. And then it has no P waves and it has like those weird wide QRS complexes.
Yeah, perfect. So that goes back to my SA node fires 60, 60 to 100, 20, whatever. So with an idioventricular rhythm, it's kind of getting generated in the Purkinje fiber. So I don't have a P wave. Anything starting in the ventricles is going to be a very wide QRS. So
is this one the idioventricular?
Yeah, so this one's idioventricular, but this is probably accelerated because my ventricles usually fire 15 to 40. Is that what the textbook says now, 15 to 40?
It says 20 to 40 for idioventricular.
Oh, okay. So I don't know which group I had, but somebody showed, I think it was Megan, showed me in the textbook, it said 15. So I've always known 20 to 40. It's potentially 15 to 40. But yeah, okay. So idioventricular rhythm, it generates down there. It's very slow, very wide complex, no P wave. If that is faster than 20 to 40, it's going to be considered accelerated like this one. All right. And then if it's over 100, it would be VTAC at that point. Any questions on this one? Okay. Your heart rate is over 150. So what rhythm is this probably?
SVT.
Perfect. That's your general cutoff for SVT is 150. So they can bear down, we can give adenosine, or we can cardiovert. Do we know what this rhythm is?
A flutter.
Mm-hmm. So it's a flutter. Do you guys know that your flutter can be regular or irregular? So just so you know, with the flutter, because it's more organized, you might actually have like, this shows like 3 flutter beats between each QRS complex. So it's possible for this rhythm to be regular. That's the only weird thing about a flutter. But your big giveaway is that your waveforms, there's multiple P waves and they're nice and rounded. They look a little bit sawtooth. So that's your flutter. Ooh, this is a good one. Any guesses?
Is it the PVC?
Yes, thank you. This is how obvious your PVCs are. You're kind of like, holy crap, there's this giant, it almost looks like like an IVR beat, idioventricular beat in the middle of all this. So my giveaway a little bit is, okay. So my giveaway is that this section of my EKG, and if I had kept watching this rhythm, is mostly normal. PQRST, PQRST, this rate looks okay. My PR interval is okay. So I think the overall rhythm here is probably normal sinus rhythm, but yes, you do have these giant premature ventricular beats. We're gonna skip that one. Okay. Any guesses on this one?
Is it paced atrial?
Yes. So why are you saying atrial?
Because it's like kind of like right before the P wave.
Yeah. So like you said, if your patient's on a pacemaker, you have something called a pacing spike. So that's what it's a very, very straight line. They're pretty obvious. A lot of the times they're a different color as well. So I think at least where I've worked before, my EKG rhythm was like white or green and my pacing spike was yellow. But it's a very straight line to indicate that your pacemaker has discharged. You can pace the atria, you can pace the ventricles, or you can pace both, depending on what kind of pacemaker they have in. Because this spike happened right before my P wave, this is an atrial paced rhythm. Any questions on that? All right. This is actually, we're getting good ones. So your rate is 82. Does it look regular or irregular?
Regular?
It's regular. Do you have one P wave for every one QRS?
Yes, but it's inverted.
Perfect. So my P wave is there, but they're all upside down. So where, like what rhythm does that generate?
Junction.
Yeah, it's coming from the junction. So it's no SA node, just nothing's going on up there. It's inverted, which is another indication of junction. Is it normal? Because my AV junction fires 40 to 60. Is it accelerated or is it tachycardic?
Accelerated.
Yeah, so it's accelerated junctional rhythm. Sweet. All righty. So I'll give you a minute on this one.
Is it normal sinus rhythm with PAC?
Yes, good job. Same thing, like it looks like this thing wants to be normal. So you're like, what is going on here? Like if I had to go from like these three right here, spread out pretty easily, my PR interval looks good. My rate is okay, but yeah, so it's beat number 3. This one right here, and then this one at the end, those are premature atrial contractions. And we know it's atrial because of what?
On the ones that look funky, it looks like the P wave is like piggybacking off the T, like it's happening too fast.
Yeah, so that's a great indicator too, is that this beat showed up early, so early that that P wave actually landed on top of a T wave. And I know this isn't coming from the atria because that P wave is upright. So this, I'm gonna skip it. This one's a junctional tack. I think it looks a little crazy, but you don't have P waves. It's over 100. This patient kind of has a bundle branch block. It looks like this is a weird representation of junctional attack.
I have a question about that one. Sorry.
It's okay. Go ahead.
I get that one confused. Like when I'm doing this game, I get it confused between SVT and junctional attack. Like when I look at them like side by side, I can see the difference. But when I see them like on this game, I don't know why I confuse them. Is there a good way to tell the difference?
If I remember correctly, on the SVT, you can see a prominent hump that is basically the P and the T wave sitting on top of each other. There's a prominent hump there on SVT. On the junctional tack, one is I think you have like a bunny-eared QRS complex, and you don't have that big P T wave.
Okay, thank you.
You're welcome. And honestly, I've never seen junctional tack in real life ever. So don't stress too much about that other than for testing purposes. Do you think the rhythm you're looking at, the rate is 36. Does this look like sinus bradycardia?
No.
No. Okay. So there's only really one other rhythm that you're probably going to see that runs this slow.
3rd degree.
Yeah, it's a 3rd degree block. So that should be your suspicion where you're like, this doesn't look just like a typical sinus bradycardia at 36. There's something else going on. And if I go P to P wave right here, so that's what this little hump is, because they'll happen at the same time as your QRS. All my P waves march out and they're happy because my SA node's doing its job. Because signal didn't get to my ventricles, my Purkinje fibers fire 20 to 40. So I have these, again, wide complex, because it's anything that starts in the ventricles is a wide complex. These wide complexes that are beating at roughly 36 beats a minute. So yeah, that's a 3rd degree block. All righty. You guys want to do more? Yes, no? I'm up for votes.
Yeah, maybe a little more.
Okay. Let me see if we'll do another game. Okay, play. All right. So what thing totally stands out here?
The wide QRSs.
Yeah, super wide QRS is, and there's just 2 random ones, right?
Yeah.
So what do you think this is?
Is it a NSR with PVC?
Yeah, it's PVC. Because again, the rest of my rhythm looks like it's okay, but you just have these, you have these giant beats that don't make sense. Like if the whole rhythm was all of these, then that's when you have your idioventricular. Or if you have multiple P waves, you know, like if you saw that, if you remember what that third degree looked like. So that's why these become more and more apparent to you guys.
Real quick, can you just, to refresh my memory, can you tell us what the difference is between the PVC and a PJC? Like what would I see?
Perfect.
PJC.
So a PJC, so PVCs are, I call them big, fat, and ugly. It's super wide complex, right? And it showed up early. Anything coming from the AV node that is junctional, they're very narrow complex. It's actually, they're known to be very narrow. Anything coming from my AV node, so any of your junctional beats usually have a very, very narrow QRS. So that's one key indicator. My PVCs are super wide. My junctional is super narrow. And then my PVC doesn't have a P wave, and neither does my junction. So that can get confusing. And also your junctional beat could have an inverted P wave.
Okay, thank you. That does help.
Okay, good. This one, I want to make sure it wasn't that. So my rate is 78. Does it look regular or irregular?
Irregular?
It's irregular. And I know they look a little weird, but is there one P wave for every one QRS?
Yes.
Okay. Is your PR interval bigger than one big box?
No.
So if I look here, yeah, like this P wave lands in a dark line. It doesn't go past the second dark line. So the only thing that's wrong with this rhythm, even though it looks weird, is that it's irregular. So what is that called?
Sinus arrhythmia.
Perfect. Here we go. This is, do you see how narrow these complexes look compared to your PVCs?
Yeah, I can see that.
Yeah, so anything from the AV node or what we call the junction is super narrow, and then either no P wave or upside down P wave. My normal junctional rate is 40 to 60. So what would this rhythm be?
Accelerated.
Yep. Accelerated junctional.
I have a question.
Yeah, go ahead.
What's that little, like, see how the one T wave just has that little hump?
Yes. Oh, this one?
Yeah, like, does that mean anything?
Not that I know of. I'm sure technically yes, but no.
Okay, thank you.
Nothing you would need to know. But yeah, that's a good catch actually.
I kind of wanted to ask too, does the PJCs, do they normally not have like a visible T wave as well?
So I don't know for sure, but my logic is the T wave is representation of your ventricles repolarizing. And in oh man. So technically your ventricles fired. Your signal started at the AV node. It went through and made your ventricles fire, which is why you have a QRS. So I'm assuming you should have a T wave because your ventricles need to repolarize, which is what your T wave is after having fired. But I did notice, at least on this rhythm, like they're very, they're not very prominent. That was my long way to not answer your question.
It's okay, I'll help, thank you.
Sorry about that. Like, I don't know everything, but I can kind of logic through it and at least give you that answer. What about this one?
A flutter.
All right.
A fib.
Yeah, this is honestly a nice looking fib. And I can see why you might think it's a flutter, but yeah, this is AFib. Usually your fibrillation waves for AFib are like more jagged and gross looking. We're gonna skip that one. Sorry, there's some that you definitely don't need to know. All right, your rate here. 72. Looks regular. I have 1 P wave for everyone QRS.
Normal sinus rhythm.
Beautiful. That's your flutter. I don't know who said a flutter last time. It did look like a nice AFib, but it wasn't quite that flutter. So your flutters have looks a little bit prettier.
I can definitely see it. I saw sawtooths in the other one, but realized once you corrected me, I was like, oh yeah, these are like here it's regular. So thank you.
I personally think like a real fit, like a AFib strip is going to look worse than that last one did. But yeah, when you see a flutter, you're like, oh, that's a flutter. You're going to know it. This one?
3rd degree block.
So a 3rd degree block, I still have atria firing. Do you see any representation of your atria firing here?
No.
Okay. So that was a great guess, by the way, like very, very good guess. For sinus Brady and sinus Brady and a 3rd degree block, you do have what these QRS complexes do look like this. But this one has no P wave, which means my atria have done nothing. So this whole rhythm's coming from my ventricles.
Is it the idioventricular rhythm?
Yeah. And it's idioventricular. It's not accelerated because your Purkinje fibers fire 20 to 40 or whatever your textbook says. So since this rate isn't over 40, I have absolutely no P waves, whether they're synced up or not. There's none there at all. That's how I know it's IVR. I hate these ones. It's a block. There we go.
Is it accelerated IVR?
Yeah, this is a accelerate. No, it's not. Sorry. I don't know who was asking me earlier, but with SVT,
that was me.
Okay, with SVT, you see this like there's like a huge hump between the two. And there's something about beats coming from the junction. They're narrow and they're very jagged. So that's the only indicator when I see this rhythm as to whether or not this is SVT or the other thing.
Oh, that's what I meant. Junctional tachy.
Yes.
Okay. Now I see the difference. Yeah. Thank you.
No, it's fine. So you have junctional tach. That was good. This one, I think I know which one this is. Okay. Here's the deal. This one is considered a paced ventricular rhythm. To me, that doesn't look prominent enough to be a pacing spike. Like I would question that because it's usually literally like one straight line to indicate that your pacer fired. But so I argue that this is a little weird looking. But what you do have is indication that they are being ventricular paced because that fire or that pacing spike, which is what this is supposed to be, happens right before your ventricles, like right before your QRS complex. But I don't think it's a good picture. You see the difference, right? That's definitely a pacing spike. So in this one, are we pacing my atria or ventricles?
Atria.
Yeah. So paced atrial. This is a good one. So go through all your steps. Let me see who can figure this one out.
Is it normal sinus rhythm with PAC?
It is sinus rhythm. It is a premature beat, but it's not atrial. This is arterial. So there's 3 places my premature beats can come from. Atrial would mean that there's an upright P wave, which I don't see here. And I don't see here because this is technically your T. So it's not atrial. Ventricular, what do those usually look like, a PVC? Those, no, go ahead, sorry.
Oh, sorry, that's when the QRS will be like the wide.
Yeah, super wide, right? And then what does a PJC look like? So PJC is upside down P wave or no P wave, and that's what this one's going on here. So it gets, this is PQRS, this is my T, it's not a P wave, so that's kind of what can throw you off. And then this beat is early, so this is a sinus rhythm with premature junctional contractions, or PJC. All right.
Is that SVT?
Yep. You could see more of like this prominent hump where the P and the T are overlapping, and your rate's over 150. So yeah, this one is your SVT. That one's, wait, you guys are beyond sinus rhythm, none of that anymore. This is a good one too. So my rate is okay. Does it look regular?
Is it a first degree heart?
Yes, awesome. So my rate's okay, it's regular. I do have one P wave for every QRS. And then when I go to measure my PR interval, so we'll look at beat number 2, this PR interval starts right on a dark line and it doesn't end until way over here past the next dark line. So this PR interval is more than 0.20. So I already know, and all of those PR intervals are equally long. So we have, if the R is far from P, then you have a first degree. Where's this rhythm coming from? Atria, AV, or ventricles?
Ventricle.
Yeah, I would say ventricles because it's super wide. And then my ventricles usually fire 20 to 40 or whatever your textbook says.
Is that the PVC?
So good question, actually. So the PVC is just one beat that comes early every so often. So overall, I have a relatively normal rhythm, and every so often you'll see a wide complex. With this particular rhythm, every single beat is a wide complex. So that means the whole thing is coming from my ventricles. So this is gonna, go ahead.
Is it accelerated IVR?
Yeah, it's going to be an idioventricular rhythm because every single complex is super wide. So nothing's early necessarily. They just all are coming from the ventricles. And then it's over that 20 to 40 range of your Purkinje fibers. So it's going to be accelerated. That's like the dumbest heart block. Okay, here we go. So my rate is okay. If I go to march these out, my next beat should have come here. We start over, my next beat should have come here. And then these are all equally spaced. Any guesses?
Is it PAC?
Yeah, PAC, perfect. So again, these really help when you actually can watch the rhythm move. If you're just sitting at the bedside watching it for a minute, you'll start to see the whole underlying rhythm is mostly regular. It's mostly normal sinus rhythm, but you have these disruptions. So this is a PAC, showed up early, has an upright P wave, normal, normal, PAC, showed up early, has an upright P wave, normal, 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 PAC. So, all right. All right. Any questions? Sorry, yeah, I did have to move this because I have to take off at 4. But I do want to see if you guys have any questions or need me to explain anything else. All right, we're good. When's your cardiac test?
February 14th.
Oh, you got some time. Okay. Yeah, play around on this website. I recorded this so I can send this out. you guys want to go back over certain sections. And then if you have any questions, just let me know, okay?
Thank you so much.
You're welcome. It was fun. So
Yeah, thanks so much.
Quick question.
Thank you.
You're welcome. Quick question for whoever's left. We went over this in second semester to give you some kind of introduction. Do you think it helped to have that initial introduction and then a reiteration in critical care?
Yeah.
So
Yeah.
All right. Because I didn't know, like second semester, I didn't know if it was too early, but it's, I don't know. I feel like we roll out this education for rhythms kind of choppy. So I'm trying to get
it helped because I like forgot it. And then to start talking about it, I started to remember a little bit. So I think it did help a little bit.
Okay. All right, cool. Just checking. Thank you guys.
Thank you.
I appreciate it. All right. Bye.